Hello and welcome to Prairie Pulse. Coming up a little bit later on the show, we'll profile Kelly Farms in Minnesota. But first, joining us is Gary Hart. And Gary is the director of the University of North Dakota Center for Rural Health. Gary, thanks so much for joining us today.
Thank you for having me.
Gary, as we get started, tell the folks a little bit about yourself and your background.
Well, had originally finished and got my PhD at the University of Washington, and had gone on there to be the director at the medical school there, the Center for Health Workforce Studies, and for the National Center for Rural Health Research. So I spent about 22 years there as a researcher and doing various kinds of research, and then eventually took a job in Tucson and was the director of the Rural Health Office for the state of Arizona for about 3 or 4 years, and then moved up here.
Well, that tells us a little bit about the background, but so how did you come to be, or how did you make the choice to come to the University of North Dakota?
Well, I'd worked with the folks here for a long time. They have a national reputation as being literally one of the, the elite places that do rural health service and research, and it was an opportunity. Mary Wakefield had been here, and she'd gone on to run the Health Services and Research Sources Administration at the federal government, and so they were doing a search and thought it'd be a great place to come, and right size town, and gave us an opportunity to kind of get away from the big cities and get into a smaller place.
Well, in the past, we've had Mary Wakefield on this show, as a matter of fact, but as we get started, tell the folks out there, what is the Center for Rural Health at UND, and what's its mission?
The center's, it's in the School of Medicine, so it's like a department in the School of Medicine, and its mission is, in a short, brief version of its mission, it is to increase the health status of rural folks living in North Dakota.
It's just that simple.
It's you kind of cut it down to its pieces. There's different ways we try to do that, but that's the bottom line.
Well, and maybe we'll cover some of that. I know, of course, you've talked about your extensive background in rural health care and workforce issues. Tell us more about that and how that really prepares you for this position.
Well, there's really been two parts. The first part of my career was really research, and that's part of what I need to be doing here at the center, because research is the thing it doesn't do as much of as some of the other activities it does. So I prepared that way, and of course it's a broad spectrum of knowledge about rural health care and workforce issues was gained through that. And then the experience in Arizona was that I was the director of a rural health office with all of the federal and state programs that are duplicated basically here. There's the Small Rural Hospital Flexibility Program that tries to help small hospitals survive in the tough economic times, and some of those kind of programs. So I've gained both sort of the research side of things and then the service side and the education side. I taught public health at Arizona and been participated in other kinds of things. So part of what we do now is try to help the medical students and the physical therapists and others, try to get them to go to rural areas and train them in such a way that isn't such a big transition for them.
Well, now you said you did a similar job in Arizona, but I mean, does the role differ at different organizations for the director?
Well, it is, and this office is bigger, and the state of North Dakota is more rural. I mean, it's certainly when you're in Arizona and you're in a rural place, you're gonna be a long way from somewhere. But in terms of the percentage of the population, this is, that North Dakota doesn't get much more rural than North Dakota does. With the big cities are not that big. And so it's a big emphasis, much more so than a place like Arizona, where the legislature is sort of urban-centric, because something like about 80% of the population lives in 2 cities. Mm-hmm. And so here, or 80-90%, I mean, it's huge. Phoenix is a huge city, and so when you're here, it's much more a legislature and a medical school and everybody else who cares a lot more about rural, because it's such a high priority.
Yeah. Well, I understand you've studied extensively something called rural geographic taxonomy. Can you tell us what that is and what it means?
That's got to sound pointy-headed for an academic everywhere. But really, one of the problems has been with the federal government and state governments in allocating resources to places. And what is rural? I mean, it's, like what's love? What's rural? And it's a very hard thing. So over the last 15 years, I've worked with people from the Department of Agriculture, and we've come up with some definitions of what frontier means, what different kinds of definitions of rural are. One's called a rural-urban commuting areas, and they're used all throughout the federal government now, and it's zip code census tract level to define what rural is. So when a government agency has money and they want to hit the most remote people in the country, they can identify them. Historically, they've just said metro, non-metro, which leaves 50 million people being rural, and it's much better to spend money effectively if you can hone down on those that are most have the poorest access to care, and so that's what these definitions do.
Well, I don't know if you can do this because, I mean, how are you defining rural in this region?
Well, it's again, I've been here all 4 months, so we're sort of we're just buying the different data and getting the things together to look at some of that. But basically, it's usually a combination of how population's density is, how far it is from, Fargo and Bismarck and those kind of places by road, shortest travel distance and commuting patterns and some things like that, which all sounds, not very interesting until you realize that literally tens and hundreds of millions of dollars are exchanging hands based on bills and things that are passed in the Congress that says people with this definition can get this money and people without that definition can't. So you'd think nobody'd care, but when we have hearings with people looking to see what the definitions, it's standing room only. I mean, it sounds off the path, but it really isn't.
Well, you also have extensive experience too in issues of rural health care for elderly, infants, and underserved, as you mentioned. Can you talk about this and how it pertains to North Dakota issues for these demographics?
Well, I mean, all of those groups exist in North Dakota. There's a real geographic distribution problem with hospitals and especially providers. The rural areas, the state isn't particularly have not enough of certain kinds of provider types, but they're not distributed very well. They tend to be in a few bigger places, and so there's large areas. Almost, I don't know, about 3/4 of the state is designated as national physician shortage areas, and so the idea is for us to facilitate getting providers out there. We do that through the medical school too, but we do it for lots of other entities, like I mentioned, physical therapy and a lot of the other allied health groups, physician assistants and others. And this state North Dakota has a very high percentage of elderly, and so they are the people who need the care the most. They use the most care, and because the oldest parts of the state are the parts that are way out there in the rural areas, there's the people who need it the most are farthest from it, and that's not a good formula for having good outcomes. So we're trying to help with that.
Well, let's talk a little bit, maybe if you can, how will the healthcare overhaul bill affect the rural areas in our region?
The Accountable Care Act, which is law for now, but it's going to morph. We all know it's going to morph in some ways, and so it's hard to nail down exactly what's going to happen to it. The one area where we need a lot of help in this sort of tier of northern Minnesota and North Dakota is with workforce. And the bill is filled, even though it gets no rhetoric on television or anybody else that's talking about it. It's got something like 150 pieces to it that deal with getting more providers, including public health providers and physician assistants and nurse practitioners and family physicians. And then it's probably one of the most important parts is it restructures how we pay for residency programs. That's where the physicians get their last training. And it's called GME money, Graduate Medical Education money, and usually it's always gone straight to medical schools, but the Accountable Care Act has a lot of that money going to small rural hospitals, so it's more direct, so we can support those providers as they're being trained in those kind of places. So there's a bunch of positives that way. I mean, the negative sides everybody knows about. I mean, more people get covered by insurance, and there's a lot of poorer people in rural areas, so they're less likely to be covered, so it would help in all those ways. Of course, there's all the things that you hear about all the time in newspapers and elsewhere about the mandate and whether or not that's constitutional. And I mean, there's all the parts that all of us don't know about.
So some provisions may be harder to implement, may be problematic.
Right, and there's parts of the bill, while the bill got passed, it's a law now, but while it is passed, lots of parts of it aren't funded. So, for instance, there are a bunch of workforce kind of things like having a national planning commission. And that commission's been formed, but the money's never been appropriated for them to meet. So, I mean, there are parts of it are just at a standstill until the Congress does or doesn't do something about it.
Well, can you talk about the current state of rural health care in the region? Of course, as you say, you've only been here a few months, so a short time, but have you had a chance to get out and tour any of the facilities? The
A little bit. I'm sort of still trying to get out of my driveway with my 12-foot drifts. I live out on a 5-acre little plot of land, and which is a great idea. And we've got chickens, and we've seen some of the health care because my little daughter fell off the roof of the chicken coop, and a few things like that have happened along the way. But I'm meeting most of the people at the university and things right now, and spending my time kind of reorganizing the center. And as spring goes, we're going to go on a few field trips out there and just do some big loops around the state and visit as many of the places. There's 36 critical access hospitals in rural areas. I'm going to try to visit all of them before the year's over. So,
well, and you mentioned the delivery and the access and location being the big factors in terms of people not being, I guess, as close to the hospitals and clinics as those of us who live in the major cities. But so, I mean, how do you even look at that or address that?
Well, again, we know some things about, I just talk about physicians, there's all these other provider types, but for physicians, some of the things we know is that if you recruit rural kids and you put them through a medical school that's oriented rural, and they do a residency that's rural, and they're in primary care, the odds of them going to a rural place are 5, 6, 7, 8 times more than what would be true if you took a kid from Manhattan, put him in Harvard, and tried to get him to come out here into a CANDU. It's just that makes sense, but we don't do it much. Not we. University of North Dakota is pretty good at it, but it's as a U.S. policy, that isn't how we address things. Johns Hopkins gets the same money for training people to be in the National Health Service Corps to help the poor as does University of North Dakota. And so we don't differentiate. And so there's a lot we could do at the federal level to point the money better. But we, again, it's picking those kids, training them so that they don't just go away to a city and get all their training and then don't want to go back. If you teach them that they're going, that being a thoracic surgeon is the only thing to be, and you've got to have all this huge high tech and be in a 500-bed hospital, they're not going to go to CANDU. And so you need to, have them out there when they do some of their training. They need to be going out with a rural doc and learn to deal with the ambiguity of not, being a specialist and of treating large populations, and hopefully learning to enjoy it. There's a lot of perks and upsides to it. We need to do a better job with female physicians. They're a bigger and bigger percentage of the graduating classes of all the medical schools in the country, and they've been historically less likely to go to rural areas. Well, in North Dakota and northern Minnesota for that matter, we need more of those female physicians to go to rural areas, or we're going to be even more short than we are.
Are we seeing hospitals in rural areas and clinics being absorbed by the bigger, again, not necessarily in this region, because we are seeing some of that, but again, in other places, are they just being taken over?
It varies a lot by where you are, and in some areas, the places that are hit the most economically by the recession, that's not been taking place because you usually don't make a lot of money out of those places, and hospitals that are absolutely struggling for their survival are not running around buying, or taking over small hospitals and things. In this region, it hasn't been so much that as a lot of the, Altru and Sanford and things. They do things where they help the hospitals in terms of bulk buying, those kind of things, get discounts. They help them that way. Some of them do management contracts with the hospitals, so they help with the technical part of having the right management teams with the right training and things at some of the hospitals. And then there's some where they've actually they would like to use the word merged usually, but where they've helped. But so far they haven't closed any. The fear you usually have with that taking place is when times get bad. What do you jettison first? Mm-hmm. Well, it isn't your big hospital in a city. It's a rural place. But there's not much evidence that I've seen so far. But again, I'm new, and that's true. It seems to be pretty altruistic to me.
Yeah. How does rural North Dakota and the Prairie region differ from places you've lived before, like Arizona and Washington, as you mentioned, in terms of sort of the rural populations and how healthcare is accessed?
It's older in general. Parts of Washington's really 2 states. There's the Seattle, Tacoma, that area, it's very urban. But if you go to the eastern part of the state, it's not all that different. It is wheat fields and orchards and that sort of agricultural entity. So it's a lot like here. Again, they have shortages of providers just like everywhere else, and in rural America. And Arizona is a very different kind of place. Like I mentioned, its rural places are more distant And there's less of them, and that's a smaller percentage of the population, but that's on its own set of kind of things. I mean, we're talking about, 180 miles to the nearest anything kind of places, so they have to be a little more self-sufficient maybe than some of the ones do here. But on the other hand, it's a much larger part of the population.
You mentioned the elderly population in North Dakota and the rural areas and small towns. How much of a challenge is that for your center?
The elderly, like we sort of alluded to earlier, they are the folks that if you kind of look at who uses the pie of all the resources, and it's the elderly use a very disproportionate share. Just like if you're starting to get older like me, you understand what that's about, because more and more you need to see doctors and get services. And as people get older and they got emphysema and they have all these other chronic diseases, they have to see the providers of various kinds much more often. And during those last years of life, I forget the number right now, but I think it's the last 2 years of life take up something like 70% of the health resources in the country. And so they're the users, and they need lots of care. And of course, they're the least likely to be able to travel, and they have the least resources in the areas where they are. So it's an issue. Transportation's an issue for them. And when you take them to the city and they're separated from their kids and their families and everything, they're not going to do as well either. And so there's a whole lot of issues around that.
Okay. Well, let's go back to the center. And how is UND Rural Health funded? And maybe tell us a little bit about its history, if you can.
The center's the center is funded mostly with federal money, some grants from foundations and what like. Actually, the state of North Dakota pays about 5% of the income of the center. And so it's an important 5%, and we use a lot of that for the recruitment and retention kinds of things that we're doing. A lot of the money that we get is federal money that comes to do programs for the feds that help states. For instance, I think I mentioned the Small Rural Hospital Flexibility Program. There's 36 critical access hospitals. We get grant money every year and have for a decade to go out and help those hospitals figure out ways of surviving, help them with their quality assurance, help them with their emergency rooms. We have people who go out in the field, so a lot of our staff goes out in the field and helps them. Or if we don't have the expertise, we hire somebody, a consultant of some kind, or somebody from another state who's got that expertise and bring them in for those hospitals and the administrators.
So you are making an impact then in North Dakota?
I mean, that particular program that I'm naming there is one of those. The State Office of Rural Health grant system that's paid for by the Federal Office of Rural Policy also does a lot of recruitment, retention kinds of things. They do scrub camps all over the state in rural areas, so kids that are growing up in rural places can see the vision of their becoming a healthcare professional. They get to go be with doctors and call them scrub camps because they scrub up and everything and wear masks and all that kind of thing, but all the way into middle school.
So what are your main goals as center director as you take over this position?
I always kid not to screw it up because it's well known, it's nationally known, it's doing a very good job. It's got about 60 FTEs, that's a full-time equivalent, so it's about 60 people. Again, it's the area that's my biggest challenge, and what I'm challenged the most by the dean has been to get the research side of it to be stronger. Now you say, well, that's kind of, again, pointy-headed, but the idea of doing the research is, one, it brings money into the state that we wouldn't have otherwise, because that money usually comes from the feds or from other sources, from foundations. But secondly, we have the ability to tailor it to answer questions that this legislature wants to know and that help us facilitate knowing which things work and which things don't.
Okay. And I guess if people want more information about the center, where's the best place for them to go?
Well, if you just looked up Center for Rural Health, on the web, Center for Rural Health, University of North Dakota, you'd hit our page. We also have two, once you're there, you'll find out we have two other pages. One of the sources of a big national thing we do that isn't aimed specifically at North Dakota is we run the biggest website in the world on rural health called the Rural Assistance Center, and we run the biggest one on health workforce that they pay us to run to provide technical assistance all over the country. And so we have those there, but that gives us, we gain from that because we gain all the expertise it takes to do it.
Well, we thank you so much for joining us today, and we wish you the best in your new position.
Well, thank you very much, and glad to be here.
All right. Stay tuned for more. In Elk River, Minnesota, there's a place that allows people to literally walk into the past. Through a living history program and hands-on learning experiences, the Kelly Farm offers people the chance to not only learn about Minnesota's agricultural history, but their own history as well.
The Kelly Farm started in 1850 when Oliver and Lucy Kelly came up from St. Paul and took a claim of 160 acres on the Mississippi River. Oliver Kelly and his wife really didn't intend to farm necessarily. It was more of a land speculation activity. The Kellys actually owned the property until 1901, but from about 1888 to 1901, it was a rental property. They sold it in 1901, and it went through a string of owners between 1901 and 1935. In 1935, the farm was purchased by the National Grange in a foreclosure sale and basically turned it into a historic site. The Minnesota Historical Society took ownership in 1961, and the current Living History program started in 1981.
I love the learning aspect of it because as much as I get to tell other people and teach them and get them to learn and engage in history and get excited about history and the different ways you can do things, I learn just as much, if not more, from the other people that I get to work with on an everyday basis. And so I get to communicate just a fraction of what there is for me to learn as a person as well.
The Kelly Farm today, as one of the state historic sites in Minnesota, really is an educational facility. And what we do is we tell people, and in essence teach many of them, what life was like in Minnesota's very early stages.
We have 8 very large animals, 4 horses and 4 bigger oxen. We have pigs, sheep, and all of that takes quite an effort in terms of day-to-day chores as well as raising the food to keep those critters going so that either they go to market or they become our mamas of the future or whatever. And so the livestock are one of the special things here.
We follow the cycle of the seasons. In the spring, we plant with our visitors. In the summer, we tend and harvest with the visitors. In the fall, we harvest and process and start a planting cycle again. In the winter months, we tend livestock and do, again, some of the same tasks that farmers did on the farm 150 years ago. We are a 12-month-a-year site where we have visitors coming in all the time. So it's a hands-on working place to find out a little bit more about agriculture and Minnesota's history, and indeed, generally one's own history.
We get all kinds of people, actually. A good majority of what we get are school groups. In the spring and the fall, we have large groups of kids coming through. We have a lot of kids that despite where their parents are on the farm, they're sitting in the house, especially in the house, and they just want to do something. They want to be helpful. They want to learn through the experience. They enjoy doing work, and that's the one comment we get from most parents. It's like, I can't get them to do this job at home, but they'll come here and they'll do it all day. So for kids, it's just a lot of doing. But the parents, they come in and they like to actually learn the history of the Kellys and what life was just like and how different and how things have come so far over time.
We get senior members who remember being raised on a farm and are nostalgic, and they're just a ton of fun. They probably have as many experiences as any of the interpreters, and we learn from them and they can learn from us as well.
We have 189 acres here. We have this very magical living history site that transports people in some ways back to an earlier time period and lets them come very close to agriculture.
It's so unique and so special in the history, and I guess I'm biased a little bit because I was a farm kid when I was growing up, and it wasn't 150 years ago quite when I was growing up, but it really seems like our generations continue to get more distance and away from where does the food come from, where does our clothing come from, how does that work? And so many young people, I don't think, have any chance maybe to learn about that. And this is a place where maybe they can get a touch of that anyway.
In some ways, we want to become Minnesota's family farm for generations of Minnesotans who don't have a farm they can go to anymore like they used to when they were younger, or their parents were younger, or grandparents were younger. We're going to tell more of agricultural story in Minnesota.
People a long time ago were the same as they are today. They just had to do things a bit differently. And you can get excited about the way things were done then, just as you can get excited about the newest cell phone that comes out or the newest computer.
You know, I love the place, so what can I say?
Well, that's all we have on Prairie Pulse for this week. And as always, thanks for watching.
Funding for Minnesota Legacy programs are provided by a grant from the Minnesota Arts and Cultural Heritage Fund, with money from the vote of the people of Minnesota on November 4th, 2008, and by the members of Prairie Public.